branch of the left coronary artery. And these coronary arteries, they are going to supply the cardiac muscles. Yes. So the thickness of cardiac muscle is less in the atria, left and the right atria, but the thickness of these ventricular muscles are much more, and the left ventricular muscles are much more. So sometimes these small branches of these coronary arteries is not supplying or not moving up to the end level of the ventricular muscles. Okay, and if they get blocks, so this muscle can be damaged. That is called as a coronary artery disease. So that is the applied aspect. Here you can see the descending branch. This is the descending branch. Okay, and the marginal and the septal branches. So septal branches, they are actually piercing the ventricular muscles. Then the blood is get collected into the venous system. That is a great cardiac vein. Yes. So and it will directly the all other organs. Okay, you have arterial system and the venous system. So same for the heart. The coronary arteries are supplying the muscles, and whatever the waste products are there, they are drained into the veins, and these veins they get directly open into the your right atrium. Okay, into the right atrium. Means they will directly means superior vena cava, inferior vena cava, and this all the great cardiac veins open into the right atrium. So again here you can see the different branches. Okay, this posterior cardiac vein is there. Here you can see the inferior vena cava, the coronary sinus is there. So all these are the venous system which drain into the right ventricle, right atrium. So overall we can, whatever we have discussed till now, it is given in this diagram is how the blood gets pumped from the left lung, which moves into the left side of the heart. Okay, and from the blood will go into the aorta for the different parts of the body, and from the left ventricle, the right ventricle, blood moves into the right side of the blood moves into the right lung for the pulmonary circulation, and from pulmonary circulation through the pulmonary veins, blood is again come into the left atrium. Yes, so understood till now? Yes. So you can see different walls. Okay, left atrium through the bicuspid wall, blood moves into the left ventricle. From the right atrium, tricuspid wall, blood move into the right ventricle. Yes, and then it go to the pulmonary artery. From left ventricle it goes into the aorta. Here you can see the pulmonary veins. From the lungs, the oxygenated blood gets into the left atrium. Okay. Where you will see the cardiac muscle. Okay. So this is some anatomical part. Where you will see the cardiac muscle. So it has a 3 linings. Yes. So we have a outer lining is the pericardium. Yes. Pericardium. Pericardium can be a yes, the visceral and the parietal pericardium is there. Yes, parietal layer of the serous pericardium, and there is a serous pericardium, visceral layer of the pericardium. So visceral layer and the parietal layer. Okay, and in between that there is a one space is there, narrow slit like space is there. That is called as a pericardial cavity, and some amount of fluid is present into the pericardial cavity. So that prevents the friction. Okay, that prevents the friction of the layers of the heart, and it will allows the proper expulsion of the heart and proper contraction of the heart. Yes. So pericardial cavity is very, very important. If there is damage to this pericardial cavity because of an accident or any hematoma or accumulation of blood into the pericardial cavity or any inflammation into the pericardium, okay, that is pericarditis. So that will affect the cardiac function. The left ventricle will not relax properly, okay, or the contraction part will get affected. So this outer layer is very important. That is a pericardial cavity. Inside the pericardial cavity, this is the outer layer. Okay. Inside the pericardial cavity, this is whole area. Okay. This is the myocardium. You can see the thickness of myocardium. Yes. It is the much more thicker, and it consists of the cardiac muscles. Yes. Consists of cardiac muscles. And inner to that there is a endocardium. Very thin layer is there, endocardium. So whenever your SA node generates the impulse, okay, depolarization waves will reach to the SA node, AV node, Purkinje fibers and to the ventricular muscles. Okay, so the all layers are get depolarized like this. Endocardium, then this whole the myocardium. And because of the depolarization of the myocardium, what happens? Ventricles contract. Because of the depolarization. And how this depolarization takes place? Because of the ions. Influx of sodium will causing the depolarization. Efflux of potassium from these muscles will cause a repolarization. So, depolarization and the repolarization. These are the electrical activities that are taking place inside the heart. And because of that, this muscle mass get contract. Yes? आपका skeletal muscle हुआ है? Skeletal muscle contraction. Same is happening, but only difference is more calcium influx. The contracting phase of ventricular muscles are much more. Okay, because we want more time to contract the ventricles, to pump the blood into the aorta. So that is the difference in the skeletal and the cardiac muscles. Skeletal muscles are voluntary muscles. These are the involuntary muscles. So these three layers, epicardium, myocardium and the endocardium, pericardial cavity. Okay, it reduces the friction between the layers of the pericardium. And most common condition you are getting, if there is a inflammation or accumulation of fluid, that is the pericardial effusion. Okay. Normal fluid is present in the pericardium. The cavity is only 15 mm, and that is sufficient to do the proper functioning of the heart. These are the walls. So I told you how the papillary muscles are there. So you can see these are the walls. Okay, the walls are having the cusps, bicuspid or tricuspid, and these cusps they are attached with the papillary muscles, which are arising from this ventricles, ventricular wall. Okay, so this is ventricular wall. These are the papillary muscles. These are the chordae tendineae, and they are attached with the cusp of these walls. So, what is the function of these papillary muscles and chordae tendineae? Yes, it keeps the walls in a stable position. Okay, so when the ventricles are contract, okay, so this keeps the walls stable in between the atria and the ventricle. So that is the function. So walls you know, similar walls you know. Now how the heart get functions. Okay, sometimes your heart rate increases, sometimes BP fluctuates. So you must know what is the nerve supply of the heart. Yes, nerve supply of the heart. So main nerve which dominates the function of the heart, that is the heart rate, is a vagus nerve. So we have a right and a left vagus nerve. So you can see the right vagus nerve mainly supplying the SA node. Okay, here there is a AV node, and the left vagus are supplying again the AV node and the some part of the atria and the very little part of the ventricles. So vagus mainly supplying the SA node, AV node and very little part of the atria. Yes, so that is the vagus supply. So what is the function of vagi? It will increase the heart rate or it will decrease the heart rate? Increase. So we have a parasympathetic nervous system and we have a sympathetic nervous system. So this vagal means it is a parasympathetic nervous system and it generally inhibits the heart rate. Okay, if you are cutting the right and the left vagal, so your normal heart rate is of 72 beats per minute, so it will increase up to the 200 beats per minute if you are cutting the vagal. So normal function of the vagal is to check the heart rate. It keeps the heart rate at the lower rate because this vagal, okay, vagus, these are the parasympathetic postganglionic fibers which are arising from certain nuclei present in the medulla, okay, and these nerve fibers, they are releasing the acetylcholine at their nerve endings, okay, and this acetylcholine, what it does, this acetylcholine mainly increases the permeability of potassium ions, okay, so influx of potassium ions will be there. Normally to depolarize the SA node, what we require? Influx of sodium ions. Okay, but stimulation of the vagus nerve, what is happening? Release of acetylcholine will increasing the efflux of potassium. So more hyperpolarization, more negativity takes place in the SA node or in the SA node, cardiac muscles of the SA node, and that will get decrease in the action potentials of the SA node, and it will decreases the heart rate. Okay, so in this way, with the help of release of acetylcholine at the postganglionic fibers, this vagal inhibits the heart rate, and that is very important. Our heart rate should be at the lower side, okay, not lower side, means 60 to 90 it is okay, less than 60 it is called as a bradycardia, and more than 100 it is called as a tachycardia. So but to maintain between the 60 to 90, the vagal dominance is very important, okay. Otherwise, if you are cutting the vagal, your heart rate will shoot to the 200 beats per minute. And with the help of exercise, yoga, pranayam, your vagus dominance get increased. And when you will see the athletes, okay, their heart rate is always less because of dominance of their vagus system. So that is the parasympathetic nervous system. Now here you can see the superior cervical ganglion, medial and the inferior cervical ganglion, and these are the T1 to T5, these are the sympathetic chain, okay. They are present into the, you have a spinal cord, in the spinal cord we have a grey matter, yes. So in the intermediolateral grey matter of the spinal cord, yes. So these are the some interneurons are present. So from there the fibers are going to the sympathetic chain. These are the preganglionic fibers you can see, and the postganglionic fibers, they are supplying the different part of the heart, okay, and most of the fibers they are supplying, you can see the ventricles. They are not supplying to the SA node, very little will supply the SA node, but it going to the atrium, ventricle and the right ventricle. So this is the sympathetic nervous system. Yes, sympathetic nervous system. Mainly the level from T1 to T5 through the sympathetic chain, and this intermediolateral grey horn is get influenced with this spinobulbar pathways, where the nuclei for the regulation of this nervous system is present. That is nucleus tractus solitarius and the nucleus ambiguous. So these nuclei are present into the medulla, okay. From medulla, vagal will supply the heart, and some fibers they are going to this vertebra, the intermediolateral grey matter, and they are supplying the heart also. So we have a parasympathetic nervous system with the vagus supply, and this is the sympathetic nervous system. So what is the role of sympathetic nervous system on the heart? It will increase the heart rate, force of contraction, or it will decrease the heart rate, force of contraction. It increases the heart rate, increases the force of contraction, it increases the conduction of the impulses. All the positive effects you will get whenever there is a stimulation of sympathetic nervous system. Okay? So many conditions which will stimulate the sympathetic nervous system. Exercise, any excitement, any emotion, any fear. Okay? So all this will lead to the stimulation of sympathetic nervous system, or any emotions. They are also connected with the higher centers. Yes, so all it will get stimulated this sympathetic nervous system, and when it gets stimulated, there is increase in the heart rate, increase in the force of contraction. Okay? So suppose the tiger comes in front of you. Okay, what will happen? Yes, you will fight or you will flight. Okay, so this reaction we want. So in such a reaction, our sympathetic system gets stimulated. Okay, and for to fight or to flight also, we want more heart rate, more cardiac output, more blood flow. Our skeletal muscles should be strong. Okay, we should get run very fast. So all the arrangement will take place with the circulatory system. It will increase the demand 10 times. Okay, and how it happens? It happens because of stimulation of the sympathetic system. So all positive effects we will get with the sympathetic stimulation, and the negative effects we will get with the vagal, that is parasympathetic stimulation. So that is the nerve supply of the heart. So these are the cardiac muscles, involuntary muscles. Okay, mostly they are the, you can see the these muscles, they are the branched one. Okay, and in between that there are the some intercalated discs, means this cardiac muscles get fold itself. Okay, and they forms the intercalated discs, and these muscles also get attached with the other muscles with the help of low resistance gap junctions. Okay, so with this intercalated discs and the low resistance gap junction, when the action potential is generated or SA node generates the impulse, your current is not get leaked to the other side. Okay, so it will properly moves into the different cardiac muscles. So once SA node generates the impulse, atria depolarize, immediately ventricle depolarize, and blood pumps into the systemic circulation. This process is very fast. Why? Because each cardiac muscle acts as a syncytium. Okay, whole heart acts as a syncytium. Once there is generation of the impulse, your whole heart is going to be contract. Left side as well as right side, with the equal amount of blood get pumps into the left, in the aorta and into the pulmonary artery. So this is happening because of this, the arrangement of these cardiac muscles, because of intercalated disc and the low resistance gap junctions. So it is acts as a syncytium. This whole organ acts as a single unit. Okay, that is called as syncytium. Are you getting? या बहुत ज़्यादा हो रहा है? हाँ? So thus I have drawn here the different means how the action potential you will look like. Okay, so if there is a influx, so this is the ventricular muscle action potential. Okay, so if you are introducing the electrodes and you are recording what electrical or what ionic bases are taking place inside the ventricular muscles, so we will record such a graph. Normal at the resting level, inside the cardiac muscle you will get the minus 80 or minus 90 millivolt. Okay, that is the potential. Yes, but when you are giving a stimulus, what happens? Sudden the graph it moves up because of the calcium channels. Okay, here there is a fast sodium channels get opened. The fast sodium channels are get opened, and then slight repolarization is there because of influx of potassium, and then there is a calcium channels will get open and it maintain the sustained state. Okay, it is called as a plateau. Okay, so that plateau is very helpful to contract the left ventricle and the right ventricle also. Yes, against the blood. So that plateau phase is very important, and when you will see the duration of the action potential, it is about 300 milliseconds. The action potential of skeletal muscle is only 3 to 4 milliseconds, but the action potential of cardiac muscle is 300 milliseconds, and out of that, this is 250 milliseconds you will get this plateau phase. Okay, plateau phase, and that is the importance. It will take more time to contract. And in that plateau phase, if you are giving the second stimulus, that will not going to be showing the response, because our ventricles want more time to fill, okay, and then pump whole blood into the aorta. Then only the functions of the ventricles will be more. नहीं इसमें और ग्राफ्स है, that's why. So in this way you are getting the action potential in the ventricular muscles. Okay, ventricles want more time to contract, so you are getting the plateau phase, and it is due to the calcium. This repolarization is due to again the influx of potassium. So three important ions are important: the sodium for depolarization, calcium for maintenance, and the efflux of potassium for the repolarization. The same action potential you will get in cardiac muscle and the smooth muscle also. Whereas there is a difference in the, this is the action potential graph of SA node. Yes, SA node action potential graph is very different. The resting membrane potential is also very less. The ventricular muscles, it is of minus 80 millivolt. Whereas the resting membrane potential of SA node is only minus 60 millivolt. So very rapidly it will giving the depolarization, repolarization, depolarization and the repolarization. Some different channels are play the role into the action potential of the SA node. Like here there is the influx of sodium, then this part is due to the influx of calcium here in the SA node. Whereas in the ventricular muscles, the depolarization is due to the influx of sodium. Okay, here the depolarization is due to the influx of calcium, and the repolarization is due to the again influx of potassium. And there is no plateau phase in the SA node. No plateau phase in the SA node. Thus that is the difference in the SA node and the ventricular muscles. And that's why, because of low negativity of resting membrane potential, SA node can generate the impulse at the faster rate. This is your conducting system. Okay, so we have the sinoatrial node. Here is the SA node. Then this internodal pathways impulses are reaching to the AV node. Okay, you can see. So AV node is get surrounded by some thick fibrous tissue, and also that's why it is it takes the time to reach into the impulses reached into the AV node, and there is a AV nodal delay. Then from the AV node, the impulses will reach into the bundle branch. Okay, this is the bundle branch. From the bundle of His, your conducting system is divided to the left and the right bundle branch. Okay, and then right and bundle branch, they come into up to the apex of the heart, and then it moves into the ventricular muscles, and again giving you different branches. Yes. So this conducting system is nothing but the cardiac muscles. Okay, SA node is nothing but the cardiac muscle. So each and every cardiac muscle is able to generate the impulse, but at the different rate. So all these conducting system are having the different rate and a different conduction for the transmission of the impulse. So you remember in the conduction system, SA node, AV node, bundle of His, then the bundle branches, and then the different Purkinje fibers which are piercing the ventricular thickness. And that's why you are getting the different action potential from this different the different tissues. SA node action potential will different, bundle branch action potential will get different. Okay, here you can see. This is the slow response. You can see the ventricular muscles, you are getting the plateau phase. Atrial, the Purkinje fibers will get slightly plateau phase. Okay, bundle branches will get plateau phase, but the action potential of SA node, there is no plateau phase. So you just remember the difference. So that is. So these are the learning of the objectives, because I think this part is important for you. Conduction of the impulse. Why there is a AV nodal delay is important is it will give a proper time to fill the ventricles. That is the importance of AV nodal delay. Okay? So from this diagram again you can summarize the conducting system of the heart. How the SA node impulses will transmitted with this internodal pathways into the AV node, and then from AV node to the bundle, right and left bundle, and then to the Purkinje pathways. So this is the conduction velocity, okay, in the different tissues. Like the SA node, the conduction velocity is 0.05 meter per second. Internodal pathways from SA node to AV node, the conduction velocity will slightly increase 1 meter per second. When it will go to the AV node, again it will be 0.05. You can see the bundle of trees 1 meter per second. But here you can see the Purkinje fibers. The conduction velocity suddenly increase. That is the 4 meter per second. Means once the impulse is transmitted beyond the AV node. Okay. So Purkinje fibers will very suddenly transmit the impulse to the ventricular muscles. And there is a fast contraction will take place. Don't talk. So the transmission, the impulse conduction and the depolarization is also having some sequence. Okay. So the sequence is first the atria, both the atria will get contract. Okay. Then what happens when it comes to the AV node? Okay. Your septum will get in the two ventricles. We have a atrioventricular system. The ventricular septum is there. So ventricular septum will get depolarized from left side to right side. Okay, like this. And then the depolarizing waves going into the septum and then to the ventricles. So here you can see like this. Depolarizing wave is moving, then it is transmitting to the different ventricles. So in this way, the depolarization of the heart is taking place. Atria, then the septum from left to right, depolarizing wave going up to the apex, and then both the atria and then the basal part of the heart will get depolarized. Yes? So the contraction is like this. And the part which get depolarized late, okay, that will get depolarized first. That is the rule of the heart. So the depolarization is like this. Okay, depolarization is like this, and depolarization is also like this, means opposite. So depolarizing wave is coming from here to here, and that's why the ventricles will get again the more time to contract and to pump the blood to the systemic circulation. So here is the time is taken, how much time is required to transmit the impulse. So from the SA node to the point 22, okay, the second is required to transmit the impulse to the whole heart. So how this impulse is transmitted? Purkinje fibers and then to the whole ventricular thickness, okay, like this. So depolarizing waves is moving like this. So this is the importance of the nodal delay. Okay, it allows the ventricular filling. More time will get to fill the ventricles from the left side from the atria and the right side from the right atria. Okay, it maintains the low ventricular rate in the atrial fibrillation, and some drugs which are acting. Okay, digitalis, beta blockers. It reduces the heart rate by promoting the AV nodal delay. Means these drugs are act on this AV node and it increases the or it decreases it increases the time duration for the transmission of the impulse. Okay, so that will help again the more filling of the ventricles and the more pumping of the heart. A vagal stimulation will cause the AV nodal block. बहुत ज़्यादा stimulation दिया वेगस का तो क्या होगा? Impulses will block, okay? Decrease in the heart rate and the blockage of the AV node will be there because SN node impulses will not transmitted to the AV node. So there is a AV nodal blockage will take place. So that is the importance of the. So this topic is again very important for you. Cardiac cycle. So cardiac cycle, you should know, you should define the cardiac cycle and you should know the different phases of cardiac cycle. You should know how much is the atrial systole, atrial diastole, ventricular systole and ventricular diastole. Pressure changes are not much important, but when you are recording the blood pressure, okay, your systolic blood pressure is how much? Combine the practical blood pressure 120 mm of Hg and the diastolic 80 mm. So these pressures are actually they are present into the left ventricle and the aorta. Okay, and with that pressure only your circulatory system are able to pump and able to reach the blood up to the last tissue of your body. Okay, so that much normal pressure should be present in your blood vessels and your heart. Okay, so pressure changes along with the volume changes are very important. So this cardiac cycle is nothing but it is the mechanical events, okay, taking place because of this electrical activity in the heart. Okay, the atrial depolarization is there, ventricular depolarization is there. Because of that depolarization and repolarization, the mechanical events are takes place into the heart. That is systole and the diastole, or contraction and the relaxation. Okay, so these three activities you have to connect in the cardiac cycle. So we will see the different phases of the cardiac cycle. Okay, so this is the heart. Okay, it is written that the all valves are closed and no change in the chamber size. Okay, in this diagram what happens? Blood comes into the ventricles, okay, from the pulmonary veins and from the right side, superior and the inferior vena cava, and the atrial contraction is already taking place. Because of atrial contraction, blood moves from the atria to ventricle, and then walls get closed. AV wall get closed. Okay, AV wall are closed, and your semilunar walls are not yet opened. Okay, so your ventricles acting as a closed chamber. Yes, so this is the isovolumetric contraction. Okay, means atrial depolarization is already there and the ventricles now are in depolarizing phase. Why these valves get opened and the closed? What is the mechanism behind that? How it happens? Just only single reason is there. Yes, pressure difference. Simply the pressure difference. जब blood atria से ventricle में जाएगा, so what will happen? Pressure in the ventricles will increase, and the pressure in the atria will decrease. Okay, so decrease in the pressure in the atria, increase in the pressure in the ventricle, the valves will automatically close. Now the ventricular pressure is increasing. Okay, as compared to the aorta, ventricular pressure is 120 mm of Hg, aortic pressure is 80 mm of Hg. So with that difference, what will happen? Your semilunar walls will get open. So only because of pressure difference, your walls are get closed or get open. And this only mechanism takes place into the cardiac cycle. And we are giving the different name of the different phases. So here there is a isovolumetric contraction. All the walls are closed, ventricle acting as a closed chamber. Blood is present in the ventricles and the closed cavity is there. So what happened in that? There is a sudden increase in the pressure in the ventricles, like from 80 mm of Hg to 120 mm of Hg. Okay, and increase in the pressure in the ventricles. Your semilunar wall will get open, aortic and pulmonary wall will get open, and aortic and pulmonary walls open, AV walls are closed. Okay. So there are two phases in this. The rapid ejection phase. As soon as pressure difference is more blood will get ejected initially. Yes. Because of ejection of the blood into the aorta, there is again slight increase in the pressure in the aorta. That is from 80 to 110 it will increasing. Okay. So that pressure difference will slightly decrease the blood flow. So we have a rapid pressure in the ventricle, the aorta will increase. Then there is a slow ejection phase. Okay. So in this ejection phase, the blood will get pumped into the aorta. And what is the nature of the aorta? Aorta is a very pulsatile artery. Okay. Means more and more amount of blood can accumulate into the aorta because of some the difference in the structure of the aorta. Okay, presence of smooth muscles and elastic fibers. So the aorta is having a pulsatile nature. More blood will get accumulate and it will push the blood into the systemic circulation. Yes, or this aorta and the large arteries, they are also called as a Windkessel vessels. Okay, Windkessel or Windkessel vessels. The other name for this pulsatile arteries. Now blood get pumped into the aorta and the pulmonary trunk. Now what happens here? Pressure in the ventricles will get decreased. Okay, and by that time the depolarizing wave of the ventricle will also diminish. The repolarization of ventricles will get started. Okay, so decrease in the pressure in the ventricle will close the aortic and pulmonary trunks. Yes, got it? Close the, because the pressure decreasing in the ventricles as compared to the aorta. So aortic wall will get closed. Yes. So all the walls are closed and the AV walls are again able to open because slowly the ventricular pressure will decrease and it will decrease up to the zero. Okay, it will decrease up to the zero. The atrial pressure is again 0 to 2 mm of ST. Okay, so there is decrease in the pressure in the ventricle in the isovolumetric relaxation. This whole ventricle is in the relaxation. So from 120 to 80, 70, 60, it will come down up to the 0 mm of ST of the ventricles. Okay, that is the isovolumetric relaxation. No change in the chamber size. Okay, no change. Here you can see this chamber is increasing in quantity. Yes, when the blood comes from the atria, the end diastolic pressure, the volume in the ventricle is about the 130 ml. Okay, out of that 130 ml, the ejection, most of the blood will get ejected into the aorta. Yes, so about 70 ml of blood get ejected into the ventricular system, and the remaining blood is present into the ventricles. All the blood is not get ejected. Yes. So before the contraction, amount of blood that is present in the ventricle, that is called as a end diastolic volume. Yes. Amount of blood that is ejected into the aorta is called as a stroke volume. Okay, it is about 70 ml. And the amount of blood that is remain into the ventricle is called as a systolic volume. At the end of systole, blood remaining into the ventricle, that is end systolic volume. So that is about the 50 to 60 ml. Okay? So no, all walls are closed and no change in the chamber size. Now what will happen? Your ventricular pressure is decreasing up to the 0 mm of ST, and by that time what happens? Atria get relaxed. Because of the relaxation of atria, blood is accumulating into the atria. The right side from the superior and inferior vena cava, and the left side from the pulmonary veins. Because of accumulation of blood, the pressure in the atria will increase, and it will increase more than the ventricular pressure. Suppose the pressure is about 2 to 5 mm of ST into the left atria, and the pressure in the ventricle is about 0 mm of ST into, because of pressure difference. AV walls will open. Atrial pressure is more, ventricular pressure is less. So AV wall will open, and there is a rapid filling of the ventricles will take place. Okay, so most of the blood will get accumulated from the atria to the ventricle, and very small amount of blood is left. So filling phase, here you can compare the size of these ventricles. So filling phase, the blood enters. There is increase in the ventricular size. Yes. So in the filling also there is a rapid filling phase. When the pressure difference is much more, rapidly blood will move. Then as soon as the pressure in the ventricles build up, there is a slow filling phase. And by that time, again the SA node generates the impulse, atria will get depolarized and the atrial contraction will take place. It is called as the atrial systole. And in the atrial systole what happens? Because of the atrial systole, atria get contracts and again some amount of blood will get pumped into the ventricles. So that pumping is due to the atrial systole. So atrial pumping the blood into the ventricles and ventricular size will increase and the atrial size will decrease. So now slowly because of accumulation of blood into the ventricle, pressure in the ventricles will increase from 0 to 10, 15, 20 like this. Okay, and by that time what happens? Atrial pressure is increasing. So because of that again AV wall get closed. Okay, and that produces the heart sound. That is called as a first heart sound. Okay, first heart sound because of the closure of AV wall. So here you will get the first heart sound. When these similar walls are get closed here, you will get the second heart sound. Okay. The third heart sound is due to the rapid filling phase, because when the blood is very rapidly rushed into the ventricles, it produces some sound that is called as a third heart sound. And atrial contraction will also produces the some sound that is called as a fourth heart sound. So these four heart sounds you can hear with the stethoscope. So are you getting the different phases? Yes. So this is isovolumetric contraction. This is ejection phase. When the ventricles are relaxed as a closed cavity, that is the isovolumetric relaxation phase. In the filling phase, and again the atrial systole phase. So how much is the duration of the cardiac cycle? 0.8 seconds. So out of this 0.8 seconds, if you are considering atrial systole, how much is the duration of atrial systole? 0.1 second. And the atrial diastole? 0.6 seconds. Yes. Considering the ventricular events, the ventricular systole 0.3 seconds and the ventricular diastole 0.5 seconds. Again, there are the different things. Each different phase are having the different duration, but we will not go to the much details. So this is the pressure volume change part. Means actually the pressure in the atria, you can see it is ranging only from 10 to 20 mm. This is the black line. This is the atrial pressure changes. Okay. This red line is the ventricular pressure change. Like this. So it is going from 0 to up to the 120 mm of this during ventricular contraction. And then again it will fall up to the 0 mm of this. Yes. This upper line is the aortic pressure changes. So normally pressure in the aorta is 80. Okay. It will reach into the ventricular contraction. It will cross the ventricular more than 120. Okay. More than 120 mm of pressure. And then it will at the range of 80 mm of it. So normal pressure of the aorta during the ventricular diastole is the 80 mm of it, and that pressure is required for the perfusion of the blood in the arteries. Okay, and that is your diastolic blood pressure. Whereas 120, that is a pumping pressure of the heart to provide the blood into the systemic circulation during the atrial systole. Okay, that is your systolic blood pressure. So you know how to measure the blood pressure, all of you? You will take a break for 2 or 3 minutes if you want to refresh. Because just I am introduce this topic cardiac output and the blood pressure so that you will get some clinical application. Okay. So why you are tying the cuff? Okay. What is the mechanism of tying the cuff? What happens if the diameter of the blood vessel is decreased or it is increasing? So that's why I introduce these topics at your level. Okay. So you take just a 2-minute break and the factors which regulate the cardiac output. So this is the proper functioning of the heart. How will you define stroke output? The cardiac output. Yes, the amount of blood that is pumped in each beat. It is called as the stroke volume. Okay, and you have a 72 beats. So when you will multiply the stroke volume of single cardiac cycle with your heartbeat, that is 70 into 72, you will get the cardiac output. This amount of blood that is pumped by each ventricle in each minute. Okay. So stroke volume is in each beat and the cardiac output is by each minute. So that is the difference. So normal value you know 70 ml. Cardiac index is you can calculate cardiac output at rest, that is 5 liters per minute, and your body surface area. Okay, so you can calculate the cardiac index. So this cardiac index is having a separate different range as the age is advanced. Okay, cardiac index will get decreased. By the age of 10 years, the cardiac index will get increased, and then slowly your cardiac index is get declining because the body mass is going to be declining in the 60 year, 70 year, okay, and your cardiac output is yet normal one. So in that condition, your cardiac index will decrease. So the cardiac index is maximum at the 10 year of your age. Here cardiac output is more and the body mass is very less. End diastolic volume. How will you define end diastolic volume? Amount of blood that is present in the blood at the end of diastole. That is about 130 ml. Now you are able to calculate the ejection fraction. Ejection fraction is very important. When patient of any heart disease or the myocardial infarction comes to you and you will do the echocardiography. Okay. So in that one important parameter is the ejection fraction. How much is the ejection fraction of the blood? Okay, 130 ml of blood accumulate 4 iron ventrically. But how much blood is get pumped into the aorta? Okay, so that determines your ejection fraction. In heart disease patient, the ejection fraction is get decreased. Okay, so normal ejection fraction is about the 65%. And how will you calculate ejection fraction? Stroke volume divided by end diastolic volume multiplied by 100. You have to express in a percentage. Okay. So end diastolic volume, stroke volume is 70. End diastolic volume is 130 ml multiplied by 100. So you will get ejection fraction is don't talk. It is about 65%. So if it is decreasing below 50, that means your functioning of the heart is get weaker. The ventricles are not contracting proper to fulfill your ejection fraction criteria. Because of coronary artery disease, the ventricular muscles are get infarct. Okay, so that much force is not able to generate to pump the blood, and in that condition you will get decrease in the ejection fraction. End systolic volume, obviously the name suggests at the end of systole of the ventricle. How much blood is left in the ventricle? It is end systolic volume. So it is about 50 ml. So cardiac reserve. Okay, normal your cardiac output is 5 liters per minute. But in many conditions like exercise, your cardiac output can increase up to 25 to 30 liters in severe type of exercise. So this much is your cardiac output reserve. Okay, you can increase the cardiac output that much. It is called as a cardiac reserve. So amount of blood that can be pumped by each ventricle in excess of normal cardiac output. Okay, so in non-athletes the cardiac output can increase up to 15 to 20, and in the athletes it can be increasing up to the 30 liters per minute. These are the physiological conditions which affects the cardiac output. Okay, like the exercise will get increase in the cardiac output, anxiety, emotions, excitement, environmental temperature. After eating, there is increase in the cardiac output. Pregnancy, you will get much more increase in the cardiac output. Okay, so because of increase in the cardiac output, patient will get the anemia, because blood volume is increasing as compared to the hemoglobin concentration, and most the females you will find there is a anemia. The HP will be less than 10 gram per cell. The pregnancy condition will decrease the cardiac output. Standing from lying position, yes, patient is in lying position and suddenly it gets stands. Okay, so in that condition there is slight decrease in the cardiac output, but it will get corrected within a fraction of a second. Then the excessive sweating, fluid loss is there because of excessive sweating, it will get decrease in the cardiac output. Condition that do not change the cardiac output, sleep, and the mild to moderate change in the environment. There are some different methods to measure the cardiac output, but which method we are preferring? These all are the indirect methods. Okay, direct method actually you have to introduce the catheters and you see how much is the oxygen consumption in the arteries and the veins and how much the total oxygen consumption. So mostly we are using the indirect methods to calculate the cardiac output, and the routine one is the echocardiography. सुनावना आपने टुडे इको करना है. So in this echocardiography you can measure the size of the chambers, thickness of the chambers, the walls, okay, whether they are normal or abnormal, how is the flow, okay, how much is the stroke volume. Yes, all this you can measure, parameters you can measure into the today echocardiography. Ejection fraction. So once you are doing the ECG, electrocardiography, okay, in that we have a PQRST waves, and these waves are nothing but the atrial depolarization and the ventricular depolarization and repolarization. So the echocardiography and the ECG, these two are the very, very important investigations once the patient comes to you with any cardiac symptoms, okay, chest pain or palpitation or fainting like attack like this. So factors affecting the cardiac output, okay. So which are the factors which affect the cardiac output? So important word is the preloaded factors and the afterloaded factors. Preload means how much blood is coming into the atria, okay, and then to the ventricles. These all are the preloaded factors. And the afterloaded factors means against how much resistance the aorta and the ventricle is pumping the blood to the systemic circulation. These are the afterloaded factors. Okay. So preloaded factors and the afterloaded factors. So one important factor in the preload is the venous return. From superior and inferior vena cava, how much blood is coming into the right ventricle, and from pulmonary veins into the left and right atria. So that is the venous return, because whatever the blood is going, that it will be get utilized for various purposes of the same function, okay, and all the waste products CO2 will get accumulated in the venous system, and then all these veins get drained into the superior and inferior vena cava, and all this blood get pumped into the right atria. Yes, so this is called as a venous return. This is called as a venous return. So this venous return is very, very important. If venous return is increased, your cardiac output will increase. If venous return will decrease, cardiac output will decrease. Suppose patient is meet with some accident and there is a sudden blood loss is there. Okay, so what happens in that condition? Your venous return is decreasing. Yes, so your stroke volume will decrease and your cardiac output will decrease. So in this way you have to see the patient and you have to analyze the condition, what is happening here. Okay, so venous return is very important to maintain the cardiac output. Skeletal muscle pump when you are walking, the skeletal muscles they are contracting, and inside the skeletal muscle your venous system is there. So they are actually contracting and pushing the blood towards the heart side. Okay, so this skeletal muscle pumping, when you are taking the deep breath, what happens? The thoracic cavity is increased and they compresses the blood vessels in the thoracic cavity, in the abdominal cavity, and because of the compression the blood is again pumped into the superior and inferior limb. So skeletal muscle pump, thoracic pump, abdominal pump, extracellular fluid volume, sympathetic activity, stimulation of sympathetic stimulation or sympathetic nerve supply is not only to the heart but it also supplies to the different blood vessels. Okay, that is called as a vasomotor flow. So these blood vessels already have a certain flow, and when the stimulation of sympathetic, there is a vasoconstriction. The blood vessels get constricted. Okay, and that will also help to push the blood towards the heart. So increased sympathetic stimulation, there is a vasoconstriction, will increase the venous return. Okay, so don't go this. Mainly these are very important: skeletal muscle pump, thoracic pump, abdominal pump, sympathetic activity. Okay, so these are the factors which will increase the venous return and finally the cardiac output. So here there are the different walls are present in the brain. Okay, distal walls and the proximal wall. So distal walls are there always closed, and that's why the blood is always pushed towards the heart. So when you are doing exercise, what will happen? Continuous contraction of skeletal muscles and continuous pushing of the blood from the peripheral system towards the heart. So this is the diagram. How when the muscle is get relaxed and how the muscle is get contracted. So there is a moving of a blood from the periphery towards the heart. So these are the factors which affects the action of the heart. Okay, different drugs. I told you the digitalis like caffeine, theophylline. These drugs will affect the myocardial contractility, myocardial depression because of different diseases. That will decreases the cardiac output. Whereas sympathetic system will increases the stroke volume and cardiac output. Norepinephrine, epinephrine, all these are the hormones which increases the cardiac output. Okay, so graph is moving this side. It decrease because of depression, injury to the myocardial, taking any depression drugs, or decrease in the PO2 or increase in the PCO2. Okay, all this will lead to decrease in the stroke volume and further the cardiac output. So all these factors will affect the cardiac output. The outer lobe. So these are all the pre-load related factors. Okay, कितना blood heart में आएगा, that will depends the your stroke volume and cardiac output. Now the outer load. So outer load is mainly it is the force against which the ventricular muscle fibers shorten. Okay, or ventricular muscles contracts. So it is the resistance offered against the ejection of the blood from the ventricle. And it is called as a peripheral resistance. Okay, so outer load is nothing but the peripheral resistance, and your peripheral resistance is mainly depends upon the two factors. Okay, first is the vessel diameter and the second factor is the viscosity of the blood. Yes, so how the diameter of the blood vessel affects the peripheral resistance? Because normally when the blood is moving into the any arteries or the arterioles or the capillaries, it exerts some pressure on the lateral wall of the blood vessel. Okay, and that develops some resistance. So if the diameter is decreased because of any atherosclerotic flaw or any obstruction, what will happen? Your peripheral resistance will get increased. Okay? And if there is a diameter will increase because of vasodilatation or any drug effect, your peripheral resistance will get decreased. Yes? So vessel diameter will directly affect the peripheral resistance. Increase in the diameter, decrease the peripheral resistance. Decrease in the diameter will increase the peripheral resistance. And the effects is the 4 times. Okay? 4 times. Suppose double the diameter is increased, 16 times the peripheral resistance will decrease, like that. Okay? Or 2 times the diameter will get decreased, the 16 times the peripheral resistance will increase. So this is the very important factor for the peripheral resistance, diameter. That's why because of any atherosclerotic changes in the arteries, okay, patient develops the hypertension. Yes, there is increase in the systolic and the diastolic blood pressure. Why? Because their normal elasticity of the blood vessel is decreased. Okay, there is an accumulation of the atherosclerotic plaques, and that gives a much more peripheral resistance, and that's why the blood pressure gets increased. Second is the viscosity of the blood. So what do you mean by viscosity of the blood? So normally in the blood we have a plasma and the blood components like RBC, WBC, platelets. Okay. So if both are in proportion, plasma and the blood cells, so you will have a normal viscosity and the normal blood flow is there. But suppose if there is increase in the RBC count of any condition, okay, so what will happen? The more blood cell count will be there as compared to the plasma. So that blood you can say as a increase in the viscosity of the blood. There are certain heart conditions like the septal defects, okay, ventricular septal defect or atrial septal defect. In that what happens? The oxygenated blood and the deoxygenated blood get mixed. And because of mixing of the blood, patient develops the hypoxia. Yes, deficiency of the oxygen. Saturation of the oxygen will decrease. And in that condition, the erythropoiesis will get stimulated. That is formation of the RBC. So more and more RBC will develop because of the hypoxia, and your normal RBC count is 4.5 to 5.5 millions. Okay, that will increase up to the 7 millions, 8 millions, and that will increase the viscosity of the blood. The blood will get much more thicker. It is very difficult to separate the plasma and the blood. Okay. So in all these conditions where you will get increase in the viscosity, you will get increase in the peripheral resistance. So these are the factors. So this is overall summarize of the cardiac output. Okay. So cardiac output mainly depends upon your stroke volume and the heart rate. And the heart rate is mainly depends on the sympathetic and the parasympathetic activity. Sympathetic activity and the vagal activity. And this stroke volume is depend on your preload factors, that is venous return, ventricular compliance and the atrial pump. How much the atria is pumping. And the afterloaded factors, that is the vessel diameter and the viscosity of the blood. So, and this myocardial contractility. So these factors are acting on the myocardial contractility. So overall all these factors are contributing to maintain the normal cardiac output. So are you getting this? So actually this is the overall picture of the nerve supply of the regulation of the heart rate and the your blood pressure. Okay. So one part is already discussed. This is the sympathetic system. Okay. From the intermediolateral of Dighore, it going to the sympathetic chain, and the postganglionic fibers are supplying the ventricular muscles. Second is the your vagus nerve, they are supplying the different SA node, AB node, and vagus nerve also carrying the some sensory impulses from your aorta and the carotid arteries. Okay. So if there is any fluctuation in the blood pressure or in the heart rate, so this gets sensed by these afferent nerves of the vega and the glossopharyngeal nerve. They send the impulses to the spinal cord in the medulla. Okay. And with this there is a responses are sending to the SNO via vegas. There is increase in the heart rate, automatically after some time heart rate will increase. Increase in BP, within a fraction of second BP will get normal. So this is happening because of some reflex mechanism taking place between the heart and the cardio-regulatory center, okay, which is present at the level of medulla. Now the heart rate. Just we will see the different factors which affects the heart rate. What is bradycardia and what is the tachycardia. So heart rate normal is 60 to 100. Less than 60 is bradycardia and more than 100 is tachycardia. So what are the factors? We will see age. Okay. More in infants and the children. Gender. Less in females and more in the males. Variation, diurnal variation means in the day and night. So during the day activity, we are doing the activities, heart rate is more, while during the sleeping, our heart rate is less. Body temperature, increase body temperature, increase the heart rate, decrease body temperature, decrease the heart rate. So mostly we will find whenever there is a fever, okay, your heart rate is always increased. And when the patient is admitted with a high grade fever, so always consultant asks to take his temperature chart and the heart rate chart. Okay, so whether it is coming to normal or not. Respiration. Okay, during the inspiration heart rate increase and during the expiration heart rate is increasing. Environmental temperature will affect the heart rate. Food intake will increase the heart rate. Posture from supine to standing, heart rate is decreased due to the stimulation of parasympathetic. When the patient is supine and suddenly stand, there is change in the slight BP, okay, and that is get regulated with the baroreceptor mechanism to increase the BP, and for that there is slight decrease in the heart rate when supine to standing position. So it is one of the reflex mechanism via the baroreceptors. Exercise, obviously there is increase in the heart rate. Regulation, you know, parasympathetic system and the sympathetic system. These are the variations, okay. Physiological, you know mostly. These are the pathological variations. Fever, anemia, thyrotoxicosis, you will get increase in the heart rate, okay. Very, this is one of the vitamin deficiency disease. Arteriovenous fistula, heart failure, tachycardia, paroxysmal, ventricular supraventricular tachycardia. In all these conditions, you will get increase in the heart rate. Even it will go more than 250, 300 like this. Yes? So you have to manage with the drugs. Causes of bradycardia, physiological athletes, fear, greed, very old age and the yogis, it will get decrease in the heart rate. Even in pathological, myxedema. What is myxedema? There is hypothyroidism. Okay? So there is a disease condition. Decrease hypothyroidism. So thyroid hormone is mainly maintained your normal basal metabolic rate, and that basal metabolic rate is very much decreased in the hypothyroidism, and you will get decrease in the heart rate. So the severe disease of hypothyroidism is the myxedema, and you will get decrease in the heart rate. Patient is very lethargic, very sleepy, very low heart rate, and opposite to that, if there is hyperthyroidism, you will get increase in the heart rate, increase in the temperature. Another condition is the brain tumors, obstructive jaundice, the drug like digitalis, you will get the bradycardia. Just we will see about the mechanism of your BP measurement. Okay, this is one of the important practical for you. So that's why I added this topic, the hemodynamics of the circulation. So the function of the circulation, you know, transport of nutrients, oxygen, hormones and collection of the metabolites. So I am setting the time or just take 10 minutes. control of the blood flow to the skin and regulate the heat loss, okay, and other defense mechanism which can, because blood carries the antibodies and all that, platelets and leukocytes. So components of circulation, you know. So there are 4 types of different vessels are there. This is also, you know, systemic circulation and the pulmonary circulation is, that is the kind of summary. So when you will see the different arteries, okay, now we reached up to the aorta. It is a pulsatile artery having the pressure of 120 mm of Sg, okay, and at the diastolic or the normal level it is about 80 mm of Sg. So when the arteries are moving up to the periphery, okay, they are divided into the large arteries, small arteries, then the capillaries, veins, venules, okay, small veins like that, and then the vena cava. So you can see the pressure in the different arteries and the venous system, okay. So from the aorta, pressure is going to be decreasing, from the small arteries, then the arterioles and then the capillaries. So at the level of capillaries, pressure is very less. So what is the main function of capillaries? It is a very thin blood vessel, okay, just a simple endothelial line. So it is the exchange of the substances. All the substances are exchanged at the level of capillaries, and then from capillaries your veins, venules will get started, and then the small veins, large veins and blood drain into the veins. So pressure is going to be decreasing as you are coming from aorta to the venous system, okay. Given the conduct or the rate of transmission of the blood flow is also decreasing. So at the capillaries, blood flow is very slow, and that is very important. If the blood is very fast, nutrients will not transmit to the tissues, okay. So blood flow is very less with the less pressure. So these are the differences. So high pressure is in the arterial tree, low pressure in the venous side of the circulation, okay, and the large pressure drop across the arteriocapillary junction. You can see this line. Suddenly the pressure is dropped from 80 to 30 mm of Hg from the arteries to the arterioles. So arteriole is the site where you will get the maximum resistance, okay, maximum resistance. So this the peculiarity of the arteriole, it consists of the large amount of smooth muscles, okay, and because of contraction of the smooth muscles, arteriole will decide how much blood should go into the capillaries, okay. So arteriole is the highest site of resistance in all the circulatory system, and because of the presence of smooth muscles, so it is acts as a sphincter, okay. Aorta से इतना सारा blood आया है, but how much it should be pushed to the capillaries, okay. So this arterioles acts as a sphincter. Again you will compare the cross-sectional areas, okay, of the aorta and different arteries. So you can see the capillary is having the very large area, 2500, okay, centimeters square. So large area is occupied by the capillaries for the exchange of the blood as compared to the other vessels. So these blood vessels, they are also having the 3 different layers, tunica externa, media and the tunica interna. And when you will come from these arteries, arterioles, capillaries, okay, this layer is also get engineered. So capillaries is a very thin blood vessel is there, whereas a aorta you will get all these 3 layers. So the difference is in the layers in the different blood vessels from the aorta, large arteries, small arteries and the capillaries. So we have 4 type of different blood vessels, okay. Midcassal vessels, so you can take an example of aorta and the large arteries. Resistance vessels is your arterioles, okay, arterioles. Exchange vessels are capillaries. Capacitance vessels are mainly the veins, okay, venules and the veins, because it acts as a reservoir of the blood. Much amount of blood is get accumulated in the venous system, and that's why capacitance vessels are the your venous system. And the shunt vessels means these are actually the block vessels, okay. But whenever the exercise and all this condition happens, so these channels will get open to provide the more amount of blood, okay. That is called as a thoroughfare or the shunt vessels. So this four type of blood vessels will be. So here the arterio, there is a constriction is there, which provide the maximum resistance. Yes, aorta and these are the capillaries. So area is more for the capillaries for the distinct. So what is the relation of the blood flow and the resistance? If there is decrease in the peripheral resistance, there is increase in the blood flow, and if there is increase in the resistance, there is automatically decrease in the blood flow. So your peripheral resistance should be within the normal range. So blood pressure, okay. So blood pressure, the definition of the blood pressure, it is the force exerted by the blood against any unit of area of the vessel. So when the blood is moving in the vessel, okay, so how much pressure is exerted on the lateral wall of your blood vessel? That is the blood pressure. Yes. So you know the normal levels. Systolic is 100 to 120 and diastolic is 80. You can calculate the resistance, okay. You know the formula of the blood flow. So you can calculate the resistance. Resistance is blood flow divided by the pressure divided by the blood flow. So you can calculate the resistance. Pressure difference between the 2 points. 2 points means arterial end and the venous end. Okay. You calculate the pressure difference and divided it with the blood flow. You will get the resistance. So here you can see the diameter is suppose the 1, okay, and suddenly the diameter is now 2. So the 16 times the blood flow will increase. Yes, 16 times it is the 4th power of the diameter. Yes, 4th power of the diameter. So suddenly the blood flow will be increasing. Suppose the diameter is 4, okay, 256 ml per minute. So that much blood flow will increase. So diameter plays a very, very important role for the peripheral resistance and the maintenance of blood. So this is the hematocrit. Yes. What is polycythemia? Have you heard the word polycythemia? Increase in RBC count is called as polycythemia. In high altitude hypoxic-like condition, there is a increase erythropoietin secretion, erythropoietin stimulation, increase in the RBC count. Okay, so this is the polycythemia. So any condition having the polycythemia will lead to increase in the peripheral resistance, and there is increase in the blood pressure. Yes, in the direct condition. So normally in your blood flow we have a laminar flow. Okay, the blood vessel walls are very, very smooth. Okay, and there is a proper distribution of red cells and the plasma, which provides the laminar blood. If there is this laminar blood flow is get affected, okay, because of any compression, because of any obstruction, this laminar blood flow will change into the turbulent blood. Yes, and in that condition, there is increase in your blood pressure. So normal, this is the laminar blood flow. Central flow is moving forward and following the other waves of the blood. Yes, that is the laminar blood. And this is the turbulent blood. So just my question is here is, so causes of turbulent blood flow is high velocity, sharp turn in the circulation, rough surfaces in the circulation, if blood vessel is injured, or some atherosclerotic plaques are developed that get dislodged and that causing the injury to the blood vessel, okay, or the rapid narrowing of the blood vessel, all will lead to the turbulent blood like this. And you will get your wall of the arteries will get damaged. Okay, the lining will not be a smooth one. Yes. So when you are measuring the BP, what is the this is the normal regulation. So when you are measuring the blood pressure with the sphygmomanometer curve, okay, you are tying the curve. So what is exactly the principle? How it check the blood flow on the your BP? Yes. So हुआ है ना practical? So curve pressure what happens? Which artery is there? Here. You are tying the curve here and you are raising the pressure. So what is doing? You are exactly in relation to this lecture. You are obstructing the blood flow. Okay. You are raising the pressure 50, 60, 90, 120 and beyond that you have to raise the pressure. Okay. So actually there is an obstruction of the blood flow in the brachial artery. And in that condition you will not find any sound. Yes. Now you will slowly release the pressure. So obstruction means there is no blood flow or there is a very turbulent blood flow. And when you are slowly releasing the pressure, your turbulent blood flow comes to the normal level. So when you are release the pressure, it's above 120 you are increasing up to 150 mm of easy. And then you are slowly releasing the pressure. So obstruction will get relieved. Slowly blood is moving into the artery. Okay, and you will hear the first sound. That will consider as a systolic blood pressure. Yes. Now again you are slowly releasing the pressure. Yes. Slowly. And one point you will get where will not hear the sound. Okay. And that point is the diastolic blood pressure. So why at this point you will not hear the sound? Yes. Anyone? Because your turbulent blood flow, because of the pressure, you are slowly decreasing the pressure. So pressure is get relieved, okay, and your artery is not getting compressing now. So your turbulent blood flow is now changed into the laminar blood flow. Because of that laminar blood flow, there is no sound. Okay, there is no sound, and that point you will mark as your diastolic blood pressure. Yes. So basic mechanism of BP measurement is obstruction of the blood flow. Okay, the brachial artery that produces the turbulent blood flow. So first sound you will hear, that is a turbulent, very tapping sound you will hear. And slowly releasing pressure, there is a disappearance of the sound. So that turbulent blood flow comes to the normal laminar blood flow. And that is disappearance of sound, and that you will consider as a diastolic blood pressure. And then you will record both these figures. Okay, that is the basic mechanism of that measurement of the BP. So these are the values. So mainly the regulation of blood pressure depends upon the vasomotor flow. Vasoconstriction will increase the BP, vasodilatation will increase the BP. Okay, or some intracellular calcium. More calcium is there, more contraction of smooth muscles of blood vessel will increase the BP. Because blood vessels are having the smooth muscles. Yes, so that will lead to increase in the tone of the vascular flow. So factors affecting the blood pressure, okay, cardiac output, peripheral resistance, stroke volume, and stroke volume is affected by preload and afterload. Heart rate is controlled by sympathetic and the vagus nerve. So all this will affect the blood pressure. So that is all. Total blood volume, increase venous, increase thoracic pump, increase pumping activity, increase atrial contraction, decrease the preload, will decreases the cardiac output and BP. Yes. Myocardial contractility will affect, ventricular contractility will also affect the blood pressure. Okay. So that is all about the regulation of the blood pressure. Certain conditions like dehydration will decreases the BP. Yes, because more fluid loss is there. In severe vomiting, severe diarrhea, more blood loss, fluid loss, decrease in the blood pressure, and you have to manage the things. diameter, viscosity, you know. Okay. These are the different variations in the blood pressure. Again, the same: age, gender, eating, sleep, exercise, posture, temperature, pregnancy. So these are the different variations. That is all about the blood pressure. We have in theory that covered all the topics on the cardiovascular system, not only the heart but with the circulatory system also. Yes? Because all these are the relation. Okay, if you are taking the blood pressure, you must know the theory. Okay, you must know the normal value. You must know the mechanisms. So that will be helpful to your understanding and again to writing the questions in the paper. Yes.